So you may wonder why I've included a section on caring for clients as individual humans in a lecture about the transition to RN practice. But I want to really go back to the basics of nursing. What is nursing? The definition of nursing is addressing, diagnosing, and managing human responses. So basically, nursing is a human-centered profession. So we're going to talk about humans as individuals, and humans as individuals exist within cultures. So what is a culture? A culture is a shared system of beliefs and values. It's how we're socialized. The culture that you grow up in is how you're socialized to live within that culture. Sometimes if we've not been exposed to a lot of other cultures, we may feel as if the things we were raised with, the way we were socialized, is the default, and anything that deviates from that is different. But every person grows up within a culture, and those cultures can be very different. There are some concepts that you need to know. Concepts always means definitions. So it's a good idea to have a separate vocab notebook. It can be one of the little mini notebooks. Write down words that you do not understand the meaning to, or that you don't already know the meaning to, in your vocab notebook as you're going through a lecture. Go back and look those up and make sure, and that will help you to understand the material better. So these are all definitions that you need to know. Okay, they might not be asked as definitions on the question, but you're going to need to know what these mean specifically in the context of culture in order to answer the questions on the exam. So some things you need to know are dominant culture. The dominant culture is the culture that is surrounding you where you are. Where we are, the dominant culture is actually in our specific parts of the country. The dominant culture is overwhelmingly Christian. It is majority white. It is majority conservative. And it is Southern US. So the way we do things, the way things are done in this culture is going to be different from someone who, from the way things are done in, say, New York or in New Zealand or in Ghana. Okay. So the dominant culture is the way, the culture that has the most representative or the most power in an area. Cultural competence is really kind of a myth. Cultural competence is the idea that we can become knowledgeable enough about the culture of other people that we can work within that culture. What we need to look at instead is cultural humility. We need to think about how that person's way of being may be different from ours and equally valid to ours. We need to understand what parts of the way we do things are culture, so that we're not imposing that on others. Cultural humility is about recognizing that people have other ways of being, and also recognizing the value in those other ways of being. Stereotyping is holding beliefs about members of a particular group and applying beliefs about a group to individual members. An example of that would be the stereotype that Asians are smart, or that blondes are ditzy, or that that men are whiny about illness, things like that. So stereotyping is applying a blanket belief about a group to an individual, assuming that that individual carries that characteristic because it's part of a stereotype. Marginalization is when a group of people is marginalized, pushed to the edges of society, and is somehow unable to fully participate in the larger culture. People are marginalized by poverty, by discrimination, by overt discrimination, and also by covert or unconscious bias. So marginalization is when people are prevented from fully participating in society. Ethnocentrism is the belief that one's way of being, one's ethnicity is the default, and everything else is a deviation from the norm. Bias is when we hold beliefs that may cause us to view other people differently because of they're part of a specific people group. Bias can be conscious or it can be unconscious. It's a really good idea for us to become aware of our unconscious biases because that can affect the care that we give. An example of how unconscious bias affects care. They did a study a few years ago, and they evaluated, they had children who presented to ERs with an injury. They took all the children that presented to ERs with a specific injury, and they compared, they selected the children who were either white or black that have the same injury, and then they compared the amount of pain medication the children were given in relation to their stated pain level. So they used pain scales and then compared that to the amount of pain medication they were given. White children were given more pain medication than black children at the same reported pain level with the same injury. So we don't have hordes of racist ER doctors who just want black children to be in pain, right? We have a lot of people who have seen in the media, and they've absorbed things they've seen in the media and messages that they've heard throughout their lives that may have impacted how they prescribe pain medicine to those children. That's how bias affects healthcare and leads to disparities, which we're going to get to in a bit. Racism is bias and prejudice. It's negative beliefs about a group of people with power. There's a power component. So I can have negative beliefs about a group of people, but if I don't have power over them, that's prejudice. Okay. If I have power over them, and this is a race-based belief, that's racism. Racism is not necessarily an individual characteristic so much as a societal issue. Racism leads to discrimination, which can be overt or it can be subtle and difficult to find. And that discrimination leads to healthcare disparities. There are really different outcomes for different groups of people that are not explained by socioeconomic differences. Another example of a disparity, and this is gender rather than race or ethnicity, but for a really long time, men were more likely to have heart attacks. Women were more likely to die of heart attacks. The reason for that was, honestly, men may not have been more likely to have them. They may have just been missing a lot more of the women's. But there are some hormonal reasons that decrease the risk of heart attack until women reach menopause. But women presenting with heart attacks were frequently treated for anxiety instead of a heart attack. They weren't even evaluated for heart attack and sent home and died of heart attack. So care is delayed because of some preconceived ideas that providers have about that particular group of people. And that's what healthcare disparities can look like. Bias is not the only cause of disparities. Poverty is a factor, and lack of availability of care is also a factor, but you need to be aware of those things. Back to culture, when we talk about culture, what makes up culture? So some of the aspects of culture are things like what people eat, how people address personal space, how close is too close. What does touch look like in that culture? And some cultures are very touchy, hugging and air kisses, and some cultures are much more standoffish. But that may not be standoffish so much as respectful of personal space. Eye contact is perceived as honesty and openness in some cultures, in the dominant culture here, but eye contact is perceived as intrusive, invasive, and rude in some cultures. Culture includes how people dress. It includes language, including idiom. So part of the culture where we are has to do with the way we talk, our the language that we use, which is different from the English that is spoken in everywhere else in the United States and every other English-speaking country in the world, because it developed here where we live. Time orientation is an aspect of culture that frequently causes conflict. So cultures with a very strict orientation to time view being on time as very important. Being where you were when you said you'd be there is very important, and failure to be on time, being late, making people wait, is rude and disrespectful of their time and energy. That makes a lot of sense to us because that is our culture's orientation to time. In other cultures, the orientation to time is more relaxed, and a 1 p.m. appointment may mean sometime in the afternoon. When someone with a stricter orientation to time is working with someone with a more relaxed orientation to time, they can misinterpret each other because it may be considered rude to show up right at the time that something's scheduled when preparations may still be going on. So those are some of the aspects of culture. When we talk about interacting, when we're thinking about interacting with patients from different cultures, what are the things we really need to know? We need to show respect always, okay? Always do your best to show respect. And that's going to cover a lot of lack of knowledge. People are going to see that you're trying to be respectful. That means we need to pay attention. We need to listen. We need to have a desire to learn about how things work in another culture. And we need to be careful about making assumptions. So what other things affect the client as an individual person? We've talked a lot about culture as the environment for an individual human, but we also want to look at the family and community environment. What other humans in that person's life present either resources or challenges for your patient? If you're caring for a patient who has CHF and they need to go home, what family members do they have, or what community resources are there that can be helpful in their care? What humans in that person's life are going to increase the challenge, are going to be a challenge in that person's care? What does the family structure look like? What are the person's responsibilities in the family and the community? The person's economic status is going to have a big impact on their health and on their ability to follow through with self-care. What coping resources do the individual have, and what coping resources do the family and community have? Sexuality is another piece of that patient puzzle. All post-pubertal humans are sexual beings. Don't make assumptions about someone's sexuality or gender. There's a strong need in our culture for accurate information because we have a lot of culture anxiety in the dominant culture about sex. So there are a lot of people who have really inaccurate information about sexuality. There are some health conditions that directly impact sexual activity, and we almost never address those. When the patient, say, has a hip surgery, they have a total hip replacement, that's going to affect sexual interaction. There are positions that could actually cause that hip to dislocate. We don't address that because we just don't want to talk about sex. That's not considered appropriate in our culture. And that can be really problematic. Make sure that you are treating patients with respect. Make sure that you are providing accurate medical information and that you are not judging your patients. That's how we need to address human sexuality. Finally, I want to talk about spirituality, because spirituality is also a part of who that person is. Spirituality is how we find hope and purpose in life. Religion may be connected to spirituality, but that's not the case for everyone. There are very religious people who don't seem to find a lot of spirituality in it, and there are people who have a lot of very strong spirituality without an organized religion. So those may or may not be connected. We need to assess our patients' spiritual needs and beliefs, especially at pivotal life moments, and look for ways to allow or facilitate their spiritual expression. We need to be respectful, make no judgments, make no assumptions. Also, not our jobs to proselytize. Okay, as a nurse, when you put on your nurse hat, it's not you're not the preacher. You don't have the preacher hat on. It's not your job to win people to your belief system in that setting. Is it appropriate to pray with patients or to pray for patients? I don't think it's ever inappropriate to pray for someone without telling them. Some people may be offended if you tell them you're praying for them, because that may feel like you're praying for them to change their behavior, or that may feel like an accusation. So it's not always appropriate to discuss it with them. If a patient asks you to pray for or with them, if you are comfortable with doing so, it is appropriate. There are things you probably shouldn't say in a prayer. I was in an ICU when a close friend had died, and there were quite a few family members and friends there, and a random other visitor came up and offered to pray with the family. And so of course the family says, okay, that would be wonderful, we appreciate it. And this person proceeds to pray this very long prayer, ending with, we really hope that their loved one knew you, because if not, we know where she is. And that's just a horrifying thing to say in the presence of people who have just experienced a loss. So make sure that you're being appropriate. But if a patient asks you to pray and you are comfortable with that, it's okay to do that. Okay, so the next piece of this lecture is going to be about communications. I'm going to come back and do the next section in just a few minutes.